Welcome to Your Case is on Hold, a JBJS podcast hosted by Antonia and Andrew Schoenfeld.
Here, we discuss the science in each issue of JBJS with an additional dose of entertainment and pop culture.
Take us with you in the gym, on the commute, or most certainly, whenever your case is on hold.
Welcome back to another episode of Your Case is on Hold. We're back here for episode 76, and we're excited that you're all here with us for another exciting and enlightening issue. Without further ado, I'd like to introduce my co-host, Dr. Andrew Schoenfeld. And you are?
I am the deputy editor for methods at the Journal of Bone and Joint Surgery.
Perfect. I'm Antonia Chen. I'm an deputy editor for adult reconstruction. And these opinions are our own. They don't reflect JBJS, JBJS board, anything like that. And this is brought to you by the Miller Review course. So if you need a good learning opportunity, you want to get everything that you need to know to pass your boards, the Miller Review course is where it's at. So sign up, enjoy it, and get your learn on because it's all really good information. So starting off with top of the pile, what's new in pediatric orthopedics by Hardsty. It's permanently free. And then cadaveric diagnostic study of subtle syndesmotic instability using a 3D weight-bearing CT distance mapping algorithm by DeCesar Neto. You also have the ankle brachial index. It is an effective screening tool for vascular injury in Schatzker type 4 to 6 tibial plateau fractures with symmetric pulses. So be sure to do your ABIs in your patients. This is by Cantor et al. Operative fires, variables associated with polymethacrylate flammability. So be careful of the fires in your ORs by Hendricks. There's 3 evidence-based orthopedic summaries, including skeletal stem cells, a basis for orthopedic pathology and tissue repair by Kong. What's important, osteoempathy, bridging surgeon and bone by Sager et al., and it's permanently free. What's important from a patient perspective, never too old to gain empathy by Hergensberg, and it's also permanently free. Do half of orthopedic surgeons change jobs within their first 2 years? An analysis using the American Board of Orthopedic Surgery database by McKeeman et al. That must be a very interesting article to find out. Do we fall into a statistic or do we not? So interesting information there. Without further ado, we're going to start with the headlines of glucagon-like peptide-1 receptor agonist decreased medical and surgical complications in morbidly obese patients undergoing primary TKA by Kim et al. There's a commentary, there's an infographic, and it's free for 30 days. So definitely go check it out.
The old Your Case is on Hold trifecta. You hit the money ball with this one. Interesting study. It was conducted by these authors using Pearl Diver data. Obviously very timely. More and more folks are on these medications in these times, either to assist with managing diabetes, or many individuals are using them for other aspects of metabolic syndromes, including weight loss, blood pressure management, sleep apnea. Seen a lot of outside the box or off-label indications for use of GLP-1s, even just within the last 6 months among patients that I'm treating even. So, certainly Zepbound, Wegovy, Mounjaro, Ozempic, Trulicity, they're all here if you want to look at them. They're all labeled here for you. But you hear a lot about these. They've really entered the popular consciousness as well. They used Pearl Diver data to look at patients with morbid obesity undergoing primary total knee, those who used a GLP-1 for 3 months before and after the surgical procedure, and those who were not. And they matched these using propensity score matching, which was done well with a pretty rigorous approach. They were matched on the basis of age, gender, diagnosis of type 2 diabetes, Charlson Comorbidity Index. The goal here, per the authors, is to balance patient groups with respect to comorbidities and overall preoperative risk profile. So ultimately, they're wanting to look at infection, complications, revision, readmission, and compare these outcomes between the matched cohorts. So there, it's a little bit of the classic data mine trope that you do see in Pearl Diver. Outcomes X in procedure Y for condition Z. In this case, the outcome, the procedure being TKA, the condition being the exposure to the GLP. The first thing to keep in mind here, of course, is that these are patients with morbid obesity on the GLPs, not individuals with a different indication or a different reason to be on the GLP medication. So, they followed a classic protocol for the propensity score matching. No problems on that front. They did find, interestingly, that individuals who were on GLP-1s were more likely to be male, diabetic, which you'd expect, as particularly in that context, higher comorbidities, and have commercial insurance compared to those who did not. And at 2 years post-operatively, the bottom line, there were no differences in the rates of all-cause revision, infection, fracture, or aseptic loosening when evaluating only patients who had undergone primary total knee between 2017 and 2022. Only medical complications and readmissions were different between the two groups. So their conclusion is that the GLP-1 administration for at least 90 days prior to and then following total knee, it was associated with reductions in the risk of 90-day PJI, any medical complications, and readmission. But that's a more narrow window. And then, as I mentioned already, once you get out to 2 years, there were not significant differences. And then they say randomized trials are needed to define the true effect of these agents on the clinical outcomes following TKA, which gets my no, don't say that. The dude, her life was in your hands paradigm.
Please elaborate.
Which part?
The dude that your life is in my hands.
Oh, that's from The Big Lebowski, where like Brandt is giving the dude, Jeffrey Lebowski, the ransom money for Bunny, and he's like, her life is in your hands. And like, he's clearly doesn't want that responsibility. He's like, no, don't say that. He's like, no, life is in your hands. Yeah. I mean, randomized clinical trials, we've said it before, we'll say it again. They can always be called for, but it's just kind of like, is that really a thoughtful conclusion for this? It's a propensity score study, which most people advertise as being a way to sort of shortcut the environment of a randomized controlled trial. And in this case, I do feel like, they did the approach well enough that you could make the case. And the findings, I think, to my mind, are as expected. When you're matching patients, those who are on a GLP-1 with the known associated benefits of that, it's not going to be surprising that they're probably going to have better. What are the things that GLP-1 gets you or is advertised to get an individual? Weight loss, improved blood pressure control, better hemoglobin A1C, improved cardiovascular profile, reduced aspects of metabolic syndrome, all of which are known to be at least tangentially associated with medical complications, PJI, and readmissions. So why do we need a randomized controlled trial for this?
Because it looks better. It sounds better. I know.
I mean, I think when you
database
consider it in the light of day, I don't think it does. Like,
no.
we don't need a randomized controlled trial for everything.
Right. You don't need to put money towards it. You don't need to do it because the findings don't change. What you do, you're going to change it based on what all these databases show, which are pretty compelling.
Now, yeah, and I mean, the only thing that you don't get here is I'm not sure that you get the counterfactual, and that's more based on the amount of the time window that they're considering, because there are secular trends in the popularity of individuals wanting to be on these GLP-1s and insurance companies wanting to approve them. So they went from January 2010 to October 2022. And I really feel like, the catching fire, the Katniss Everdeen of GLP-1 entering their, Taylor Swift era is only like in the last 2 years or something, right? Only at the very end of this study. And that's why they did this sub-analysis of patients from 2017 to 2022. And the long-term findings, as I already mentioned, at 2 years, they're not really that different. They end up in the same place. And there's no differences in the rates of all-cause revision, which you'd probably expect, right?
In that time frame, yes.
Like you'd expect there to be some differentiation between the patients. So, what benefits you get are really near-term benefits, which is fine. But yeah, we don't need to call for randomized trials in this context. I don't think.
I'll second that.
I don't think it's likely to happen.
Yeah, exactly. Will it be funded? You know what I mean? And all the work and effort that goes into it.
I mean, just think about what the costs of the GLP-1s alone are.
Right. That's expensive. People are trying to get it without insurance. And I hear you're trying to do a study. It's just a very expensive thing. So makes sense. All right. Well, last time we did a lot of spine. This time we're doing a lot of joints. So this next one is looking at perioperative geriatric assessment is associated with a lower risk of emergency department visits after total joint arthroplasty by Lamaka et al. It's free for 30 days. I have a personal vested interest in this article. Adriana is amazing and really brought this study across the line, which is fantastic. What this is that we've been working for geriatrics for a long time. It started in the trauma world, as you can imagine, where patients would come in, they were geriatric patients, and we wanted to give them the best possible outcomes. And how we did that is we had them see geriatricians who could optimize them in the perioperative space. We also expected to see that in the elective space as well, too. But there haven't been a lot of studies looking at specifically of geriatrician impact on elective total joint arthroplasty patients. So that's what we did in our study. We looked at preoperative or postoperative geriatrician involvement, understanding that some of our patients didn't get it until after surgery, and see if there was an association and a difference of the hospital length of stay and emergency room visits after hip and knee elective total joint replacements. We defined geriatric patients as greater than 85 years old, and the study was conducted from January 1st, 2010 to December 24th, 2023. And we only looked at the primary joint. If you had 2 joint replacements, they had to be separated by at least 6 months so that a single one could be evaluated at a time. Geriatrician consultation occurred within a period spanning 90 days before to 90 days after total joint arthroplasty. And then these were recorded in the charts and had to be documented. Now, if a patient went and got a geriatrician consultation outside the system that wasn't in our system, then that wouldn't have been counted. But these are patients, our total joint patients who were referred to our geriatricians. And we would create the system and said, hey, let's see if this is actually being beneficial to our patients or not. The time lapse between the encounter and the associated surgical procedure was recorded and grouped on the basis of whether the encounter occurred within 7 days, 30 days, or 90 days preoperatively and postoperatively, meaning if you were closer to the time of surgery or further from the time of surgery, both preoperatively and postoperatively, did that make a difference in terms of outcomes? And then an ED visit was defined as a recorded visit to the emergency room with a primary diagnosis relevant to the joint of interest within 90 days following the procedure. And again, these ED visits were only consideration for association analysis if they occurred after a geriatrician appointment of interest. So if you saw a geriatrician and then had the ED afterwards, that would be saying, okay, did it reduce ED visits? Did it not reduce ED visits? For a case balance, patients who had a geriatrician encounter, of which were 1,416, were first matched to patients without geriatrician encounters with an approximately 1-to-3 ratio. And then did some propensity scoring. You'll know these things better than I do, but Mahalanobis distances. And then they used logistic regressions and took in information such as sociodemographic factors, comorbidity information, age, and year of the surgical procedure. And they did bivariate and multivariate regression analysis. And it gives us the relationship between geriatric consultations and either length of stay or ED visits. So there are over 16,000 patients included in the hospital system, and 8.8% of patients had geriatrician visits. Patients who attended perioperative geriatrician appointments had higher comorbidity indices as measured by Charleston Comorbidity Index and Elix-Hauser Comorbidity Index, which is not surprising. You would say that a patient is sicker, I'm more likely to send him to a geriatrician. The multivariable logistic regression showed that patients had lower odds of needing an ED visit when they had at least one geriatrician appointment within the week preceding the arthroplasty. And visiting a geriatrician reduced the odds of an ED visit after total joint patients who were less than 75 years of age, and was more helpful for patients who were less than 65, or for patients who were 65 years old. Note that a geriatric patient was defined as a patient who was 65 years old or greater. There's a lot of arguments about that, whether or not you're actually considered geriatrics at 65, but for the sake of the study, that's how it was defined here. Adjusted analysis showed that having a geriatrician visit at any time within 90 days before the surgical procedure was not significantly associated with a difference in the length of stay measured in days. We did observe an increase in the mean age of patients undergoing geriatrician consultation and a decrease in the length of stay among patients with preoperative geriatrician visits within the study period. There was an increasing trend, but not actually statistical significance for the one where it says the number of geriatrician consults covered under Medicare that was increasing. And then ones that were significant, but again, p-values, take them with a grain of salt. An increasing trend in the number of men accessing geriatrician visits, an increasing mean of Charlson comorbidity in patients accessing this form of care during the study period. So patients were sicker. We knew that. Patients had less ED visits from that time frame, and that was really the benefit of geriatricians. And whether or not that comes from the fact that they're optimized before surgery because these are elective procedures, whether it comes from knowledge and saying, okay, if you have this condition, let's say you feel dizziness afterwards, you don't have to run to the emergency room. Potentially, you can contact your doctor's office and we can work through things. Or we can optimize you before surgery. If you have this dizziness beforehand, maybe it's orthostatic hypotension. What do you do for that? So we found that geriatricians were very helpful in with regards to something that's tangible, right? You reduce the amount of ED visits, you reduce the cost of care in the postoperative period, you reduce morbidity in a way that you have a patient go to the emergency room, have to sit to the waiting room, et cetera, et cetera. So it did justify the use of our geriatricians, which is helpful for us and our patients who are, again, 65 and above in our elective total joint process, or elective joint patient population.
Pays for itself? Intervention pays for itself?
So it's a good question. There's no full economic analysis. That would be a really interesting one to see if it does pay for itself at the end of the day. I think that the downstream effects are much greater than total joint arthroplasty alone. It's the total joint arthroplasty already has some benefits where you become more mobile, potentially more independent, things like that. But really, that you have a holistic approach to their, I would love to see things like, does it decrease the risk of hip fractures in the future, right? Because they're careful of throw rugs and they instruct people that, or, watching their polypharmacy and making sure that they don't get dizzy and fall and things like that. Those are the things we can't quantify. So potentially it could pay for itself, but in this context, in this model, we didn't look for that.
If there was a subspecialty journal called JAMA Orthopedic Surgery, would you read it?
Absolutely.
If there was a subspecialty journal that was like JBJS Arthroplasty, what do you think about that?
I'm in, but it's all about arthroplasty, and I love arthroplasty. I am biased. I am the first to admit that. But talking about biased, our next article is about arthroplasty. So your case is on hold. Vignette here is prospective non-invasive hemoglobin monitoring in the outpatient total joint arthroplasty setting by Dugdale. Thank you. 30 days free. So thank you, Dugdale. You're 30 days free. This is a group study out of Mayo Clinic. And they looked at outpatient total joint arthroplasty patients specifically. Now, outpatient arthroplasty is obviously becoming more and more popular and more common, but there are concerns with discharge with regards to orthostatic hypotension or pain-related tachycardia, which are likely related to hemoglobin levels. So this study wanted to compare a postoperative non-invasive hemoglobin monitoring with an invasive serum hemoglobin monitoring lab draw in the outpatient total joint arthroplasty setting. They wanted to look at reliability, accuracy, and patient and nurse satisfaction. So they enrolled 200 patients based on a sample size calculation of patients who were undergoing outpatient unilateral total joint arthroplasty, of which 157 were ultimately included in the final analysis, 94 hips, 63 knees. Postoperatively, both the non-invasive and invasive hemoglobin values were obtained at a mean of 36 minutes apart. Receiver operating curve analyses were performed to investigate the ability of the non-invasive monitoring to predict invasive hemoglobin monitoring of less than 11.2. And this is because it was the 5th percentile invasive hemoglobin value there. So what happened here is, in the results, they found that the mean preoperative hemoglobin, invasive hemoglobin, was 14.2, and the mean postoperative invasive and non-invasive hemoglobin values were both 13.3 with slightly different standard deviations. That said, they looked at this Bland-Altman 95% limits of agreement, and they said it was between minus 3.2 and positive 3.1, indicating that 95% of patients' invasive hemoglobin levels are expected to fall between those limits relative to the non-invasive value of the patient. But the kicker is there were some correlation coefficients here. And the correlation coefficients basically see how the measurements work between the two of them. And there are two of them were called the concordance correlation coefficient, or CCC, and the interclass correlation coefficient, or the ICC. And both of them in the study were 0.33, which is considered poor. As the authors know, anything below 0.5 is poor correlation. Note that also that when it came to the sample size calculation, they assumed that a standard deviation of the differences would be 1.8. And based on that, they said that the half width of the 95% confidence interval would be 0.43 grams per deciliter for the overall group, with a target enrollment of 200 people. That said, assuming that their ICC of approximately 0.7 would be observed, they found that they said that the sample size would yield a reasonable 95% confidence interval. So the confusing part about that is that they assumed that the ICC would be approximately 0.7, but they only ended up with the ICC of 0.33. What they did say in terms of values were among the 6 patients with a non-invasive hemoglobin of less than 11, their corresponding invasive values were higher than their non-invasive values in 5 of the 6 cases. So meaning the non-invasive one underestimated the hemoglobin level. And then their big take home was a non-invasive cutoff value of less than 12.7 grams per deciliter, had 100% sensitivity, but only 67% specificity for detecting a invasive hemoglobin of less than 11.2. Now, not surprisingly, patients reported less pain with the non-invasive test, and 97% of the patients preferred the non-hemoglobin test based on just taking the test, not based on accuracy or what it came out as. They found that based on a survey, 73% of responding patients and 83% of responding nurses were somewhat more reassured to significantly more reassured about same-day discharge. So the take-home message was saying, well, we now have non-invasive hemoglobin to do our measurement for our hemoglobin so that we can feel comfortable sending patients home on the day of surgery. And my real question, which they do address, is that do we really need it? As long as the patient's hemodynamically stable, we typically don't check hemoglobin postoperatively for our patients, both outpatient and inpatient. It's not as clinically meaningful as it was before. We used to check hemoglobin hemoglobin and hematocrit every patient the next morning after surgery. We just don't do that much anymore because as long as the patient's hemodynamically stable, they're going to go home. And we know that there's going to be a drop in hemoglobin afterwards. Now, the authors do note that there's a role for non-invasive hemoglobin monitoring as a potential first-line screening assessment for clinically meaningful anemia, especially if someone says, oh, they're tachycardic or have dizziness or had lightheadedness. So you can do this, very quick method of reading hemoglobin. The problem is that, these are not well correlated to the gold standard, pooling of hemoglobin. So, I kind of liken this to, the Theranos finger prick versus, actually drawing blood. And the difference here is we're not even doing a finger prick. We're just putting a little, almost like a pulse ox thing on here, I'm guessing, because the problem is in the certain patients, it's not going to be useful. So patients who have fingernail polish, skin pigmentation, they said, body mass index, hematological disorders, that non-invasive hemoglobin may not be that useful. So would I go out and run and buy this monitor? Probably not, because if I need a hemoglobin value on a patient that I'm really concerned about, I'm pulling a hemoglobin from their veins. I'm not sticking a machine on their finger. I don't need it to discharge a patient. Now, if someone mandates me that I need a hemoglobin before discharging a patient, then yes, this makes sense. But can't ever foresee that being the case.
Like, first off, I love the way they call it like invasive, which it is true, but it's not like you're putting a central line in to get the hemoglobin, right? Like it's like a regular blood draw.
It's like tap, little butterfly, go.
Yeah.
Not an A-line.
I mean, I think you hit it on the head 100%. It's like if there's any doubt, you're going to want the actual hemoglobin. And if there really is no question, then you don't need the non-invasive thing, to which there seems to be this, a 1.5 difference. It's like if it's less than 12.7, it'll probably be less than 11.2 in reality. That's like, well, then it just should probably be calibrated better, right? I had questions about the calibration, the correlation, and some of that may just be due to the fact that they did ultimately only include 200 patients. So you'd get, if you had 1,000 patients, you'd get a better, and that was one of the things where I was just kind of like, why did you just set it at 200? Like it's a prospective study that doesn't really require too much. A place like the Mayo Clinic, a very high volume facility, could probably get to 1,000 patients, no problem. And 1,000 is just arbitrary. Like, I mean, that's like sort of the general cutoff for a lot versus not so much. It could be 500, it could be 800, it could be 750, whatever. More than 200. At the end of the day, once you saw this, to me as a researcher, you say, all right, we need more.
Exactly. I need more information before I can use it regularly.
Right. And again, it's just like the premise itself. It's like at no point, or if you suspect it, you're going to want the actual hard objective data, the gold standard. You're not going to rely on if you're already asking them when it's not required, in the scenario where it's not required, if you're asking them to do the non-invasive hemoglobin measure, you're probably at the point where you want it drawn anyway.
Or you need a rapid transfusion protocol and you are like, like get that quick and stat and let's just start pumping blood in. So,
and one other point I wanted to make is that this 12.7 to 11.2, right? That's highly predicated on their clustered sample, right? Like they probably didn't have like a patient that had a very low hemoglobin just based on the nature of the surgery and where things are, right? So it's not going to be 1.5 that just has like two parallel lines of 1.5, so that when it's 7.5, it's really 6. Like once you get to like 10, it could be that the non-invasive one is telling you 10 and the actual value is like 6, right? Like,
so true. It's arbitrary in that way. All right.
Unknown.
Honorable mentions. We're going to talk about more arthroplasty. Outcomes following direct anterior approach, total hip arthroplasty, a contemporary multi-center study by Wilson et al. There's a commentary, a visual summary, and free for 30 days. In one of the largest published series to date, and we talked about saying largest published series to date.
All right, but this one, as you're finding it, is a little bit more legitimate because it's a contemporary multi-center study of patients. So while, again, we encourage caution, it's really like probably just refrain from saying it when you're talking about your Pearl Diver, your TriNet X, your Mariner database, your NISQIP, your NIS. Here, there's a little bit more like it's okay. It's permissible.
It's actually a multi-center study.
Right, yeah.
And they're looking at survivorship following direct anterior total hip arthroplasty, and it was satisfactory at early to intermediate follow-up. The leading indications for revisions were periprosthetic joint infection, periprosthetic fracture, and aseptic loosening. Instability after direct anterior total hip arthroplasty was uncommon and frequently led to revision. As a note of caution, a BMI of greater than 40 was identified as a risk factor for adverse outcomes after direct anterior total hip arthroplasty. Now we're going to switch to trauma. Blood and bone-derived DNA methylation ages predict mortality after geriatric hip fracture, a pilot study by Tarpada et al. And the purpose of the study was to perform the first analysis of bone-derived DNA methylation and compare DNA methylation clocks derived from bone with those derived from whole blood, and then to establish a relationship between DNA methylation age and 1-year mortality for geriatric hip fracture population. And this study found that bone-derived DNA methylation clocks were found to be feasibly and strongly correlated with those derived from whole blood within a geriatric hip fracture population. Mortality was independently associated with the DNA methylation age, and that age was approximately 17 years greater than chronological age in the mortality cohort. The results of the study suggest that prevention of advanced DNA methylation may play a key role in decreasing mortality after hip fracture. And that is hard to do with your DNA. And the final one is cephalomedullary nailing for subtrochanteric and reverse oblique femoral fractures, comparison of a single versus dual lag screw device by Ablett et al. For older patients with subtrochanteric and reverse oblique femoral fractures. The dual lag screw design of the intertan nail was associated with a lower risk of mechanical failure compared with the single lag screw design of the Gamma 3 nail. That's all, folks. Thanks for joining us today, and we look forward to having you on next time.
Remember to smash the like button, get the notifications, tell your friends, give us a 5-star rating if you can. This episode was obviously brought to you by Total Joint Arthroplasty. If you like what you heard, thanks for sticking with us. If you didn't, come back and it'll be maybe next time it'll be the special sports medicine issue or the special shoulder or foot and ankle issue. Who knows? Stay tuned. Thanks for the time you spent with us. Hopefully your cases are ready to go. But as always, the cases here are still on hold.